Today, Mr. Jack Caravanos will talk about different approaches to measuring health impacts at toxic waste sites. Mr. Jack Caravanos is a professor of global environmental health at NYU's College of Global Public Health, and he is also the director of research at Pure Earth. He originally trained in chemistry and now specializes in assessing environmental contamination and human health effects of toxic agents. As usual, this will be a 15 to 20-minute presentation followed by a Q&A session. If any of you have trouble seeing the PowerPoint, please do not hesitate to send me an email to Lucie, Lucie, at pureearth.org, and we'll be sure to send you a PDF version of the PowerPoint to allow you to follow along. Please also note that we are open to any questions you may have regarding Jack's presentation. You can ask them in person at the end, but if you would prefer, you can also ask them in the chat, in the GoToMeeting chat, and that way you will remain anonymous. And the organizers will, of course, ask them for you. Now, on to you, Jack.
Greetings, everybody, and welcome to another pollution talk. Today, I'll be approaching a subject which is quite interesting and quite important in our field of public health and environmental health. It's hard to do justice to this in a short time, but I think this will be a nice primer for many of you, and we can have a continuous dialogue after this. So essentially, the question we're asking is, how do we know if a population is getting sick from an exposure? We have a child playing in lead-contaminated soil, children playing in this area. We can measure contamination. We can measure biomarkers in the blood. But how do we measure disease? Where do we start? And what information do we collect? And in our activities, we usually go in this direction. Contamination, we search for it, and then we look for exposed individuals. We generally do not go in this direction, meaning looking for people who are sick and tracking the contamination. Interesting concept. Let's find people who have a similar disease, and maybe they're all living next to a contaminated site. People do it, but generally our approach has been the other way around. The field we're actually talking about is epidemiology, and loosely speaking, it's a study of epidemics. But they do more than that. They study the distribution and determinants of disease. I love this phrase because it's two very clear words. How is disease distributed? And that can help us determine what is the cause. And the reason they do this is to determine the best corrective action to basically reduce any public health damage. And the good example is John Snow. John Snow, of course, and his famous investigation of cholera in 1854, walked the neighborhood, plotted the cases, and eventually came to the conclusion that there's a pump on Broad Street, was taking water from a contaminated source, and of course that's where the cholera epidemic spread. And his famous action of removing the handle sort of alleviated that and solved that problem. It's a fascinating story. I encourage you to look at it, but it's classic shoe leather epidemiology, or what we call field epidemiology. These are people that are walking the streets, asking the questions, which is sort of what we want to share with you today. To give you an example of some of the approaches for this, this is a very nice example of a real-life investigation. The reference is on the bottom, and it describes this in terms of time, person, and place. So let me review this. By the way, where did this data come from? An existing surveillance system, meaning someone is collecting this continuously, and therefore we can go back and look at any patterns of disease and trends. So this is a key phrase, surveillance systems. We'll get back to this shortly. And if you look at the temporal distribution by time, you see there are some interesting findings, what's going on at 11 o'clock and what's going on at 4 o'clock. And essentially what this is fatigue. It appears that the people that are working, they're very energetic in the morning, but 4 hours later, driving a tractor without a break, you get quite tired and mistakes start happening. Likewise, during lunch from 12 to 1, nothing, no disease, no fatalities. And then there's also a peak in the late afternoon. And of course, it trails on. Farmers can work sometimes very long days in the fields. So when you look at the time of what's happening, this can really be a clue to where are the toxins. For example, in our world, is it during the rainy season? Is it during cold weather, warm weather? And by looking at temporal factors, it could help us determine whether there's a common exposure or a common source of contamination. So this helps narrowing in on the cause. If you look at who's getting affected, here's the death by age group, and it seems like, oh, gee, it's the older people in the 60s that are having trouble with these tractors. But I caution you to be very careful here because these are not rates. This is deaths. So consider this, that the 60 to 69-year-old, where there are, whatever, 45 deaths out of, let's say, 45,000. So that's 1 out of 1,000 farmers has died because of tractor-related deaths. But if you look at the 10-year-olds, 10 to 19-year-olds, you could have a very a smaller group. You could have 1,000 children in that group. So the rate of disease in the teenage group was actually higher than the older group. Why? Because there are more older people working in the fields than younger. So the point here is you cannot compare raw events. You must compare rates of disease. And when you do that, things really do change because you have more, very few teenagers driving. So in epidemiology, we do compare disease. Then another factor that's very common and very important, especially in our work in the toxics world, is spatial distribution. And here you see something going on in the northern part of, this is Georgia, that a lot of fatalities are happening up here. And you're sort of wondering, well, gee, who lives there? How old are they? What are they doing differently? But the reality is it's a very mountainous region of Georgia, and therefore driving a tractor here is much more complicated and dangerous. In many ways, John Snow did a spatial analysis. And we at Pure Earth often do spatial analysis to try to ascertain the extent of contamination. Again, you need to be careful because these are not rates of disease. These are just events. So, but in reality, these are rather serious because the bottom of the state is flat. So there's much more farming, but less deaths than the northern part of the state. So spatial analysis. So again, contamination giving us a clue as to how it's affecting people. And we do spatial analysis. Here's a nice graph by some of our staff. We do this all the time. The dark red, maroon colors are high levels of lead, and the lighter colors in green are acceptable lower levels of lead. And what this means is it could help us go into the villages of each of these communities and answer the question, is there excess disease? So spatial helps us determine where to start our work. Okay, so let's continue on. How do we start? Well, this is a picture of a sick child. This happens to be a Minamata child in the 70s. And it starts over here. First, we need to collect information about the child. Now, you can actually go to the child, go to the parent, go to the sick individual, and from there determine, collect information. For example, and the way you do this is you can have them tell you, you could interview them, or you could have a standardized questionnaire. This happens for a lot of investigations. For example, in the Ebola epidemic, we were actually interviewing individual people saying, what did you do, where did you do it, how did you do it, to try to ascertain the best course of action. So, but talking to a child is hard. Talking to an adult about their symptoms is hard because you have recall bias and you have, they're not medical professionals. When you say, how do you feel? I don't feel well, as opposed to, I have irritation, I have gastroenteritis, I have diarrhea. So collecting information right from the source is difficult and may not be good enough for us. So the next place is, of course, when someone is sick, they go to a clinic. That's much better, because at a clinic you have, of course, nurses and doctors and staff. And these are professionals. They understand what the diseases are, the names, and they speak the language, meaning the medical language. So interviewing these people is generally the best course of action. There are others, and I'll present them shortly. Now, one problem is getting nice quality data would be a simple interviewing of the physician on staff and the nurse. However, when you interview people, you may lose information, so we prefer a standardized interview, or you could even give them a questionnaire standardized, saying, oh, please, once a week, can you complete this questionnaire on what you've observed and what you've seen. So direct interview can be tedious and long. Standardized interview is much more organized and formatted. And the standard questionnaire is a little difficult because they may not want to fill out the questionnaire. They may not have time. So that's why you see a professional doing an interview on the bottom. So let's continue on this track. Let's put that clinic over there on the left and say, collect our information. And what information are you collecting? Well, there are the two general categories, if I may, is acute health effects, things like headaches, diarrhea, nausea, irritation, sleep disorders, etc., and of course, chronic diseases. Chronic diseases are, of course, strongly linked to environmental exposures, so that we prefer to sort of look at chronic diseases, but many clinics don't have such records on this, or don't have extensive knowledge. So most of the times they're dealing with acute primary care. Now, the good thing is that many diseases are reportable. And that means if you have a case of cholera in any country, you must report it. And this usually goes up to district and ministry level reports. However, there is no distinct disease for lead poisoning, so it doesn't become a reportable disease. Once we have a reportable disease, getting information about causality is much, much easier. And some of the symptoms that we see in a general standardized questionnaire, and there are many available from the ministries and CDC and WHO. And if you simply Google the phrase health survey questionnaires, you'll see tremendous amounts. Some can be 1 page long, some are, of course, dozens of pages long, depending on how much information you can collect. So this is sort of the best place to answer the question, is the primary care physician at the clinic. Now, I said before that you report these diseases up, and very often it's at the ministry level or the clinic level, reportable events, and you also have other reportable events. For example, there's something called vital statistics, the Bureau of Vital Statistics, the Office of Vital Statistics. And these are people that are recording everything from births, marriages, deaths, and the reportable diseases. So these reports can be very useful for us in determining, is one community getting more disease than another? Of course, it's important that the information is available, but generally for deaths, whether it's childhood, infant mortality, neonatal, or mortality, older mortality rates, that you generally have this reporting. Almost all countries have some type of death certificate reporting. The death certificate is quite complicated. It can have, of course, the primary cause of death is generally useless because it's usually heart failure for elderly people. But what caused the heart failure? That could be the diabetes, the hepatitis, that could be asthma, that could be COPD. So analyzing death certificates is not the simplest, and there's a certain process must be followed. It was rather shocking years ago, or about a year ago, when people reported tremendous amounts of unreported deaths. Two things: unreported deaths, meaning people have died that are not recorded in any type of log, and then no cause of death reported for people. And the latter, meaning people have died, but there's no cause of death ever listed for them, is quite troubling, because in the environmental world we do have diseases that can be fatal to kids, and if we don't know why they died, they just become undocumented sort of cases. So the WHO has something called a verbal autopsy, where when someone dies, and in these villages, they will very often die in the village, not at a hospital or at a clinic. Someone is sent to do a verbal autopsy, which means answering the question. Someone would proceed down a triage of questions, finally getting to the primary cause of death and the contributing cause of death. Because as you know, people just don't die. There's always a reason for that. And death is not normal for a 2-year-old or a 10-year-old or a 25-year-old. So there must be some cause. So verbal autopsies. And of course, the accuracy of all this. And we've seen this in the Ebola epidemic, when people were dying so quickly that it was barely time to record all the information. But fortunately or unfortunately, the primary cause of death was pretty obvious, that it was heart failure due to Ebola infection. So where do I get this information? Well, in general, because we deal at the local level, the local health clinic is likely to have some information on this. So my advice is to really start there at the village clinic. How do we get this information? Well, I strongly encourage using standard survey instruments. There are many available, and we can help in sort of standardizing our systems here so that we're all asking the same questions. One big problem is staff, equipment, and skills, meaning, do we have adequate people that can recognize disease? Do we have the proper instruments and, of course, the skills? So the sad thing I have observed is that very often physicians and nurses are wonderful staff, but they don't or have not been trained to recognize environmental disease. That what may sound like just asthma, no one ever questions, well, is this due to indoor air quality and indoor cook stoves, or is it due to something else, or allergens, etc.? And same thing with lead poisoning, which is very difficult to finally ascertain. And of course, what we find is staff need to be trained. And my experience, again, has been that very often in these villages that the primary caregiver, nurse, or physician is not adequately trained for this exposure. It's not a fault of their training. It's even in the U.S., physicians generally are not trained for environmental diseases specifically, but more generally. So that very often we have to make sure that the people collecting this information know what they are collecting and how. So the field of epidemiology is wonderful. I just want to do a quick primer on a couple of things. Once you have all this information, once you've collected how many people are getting sick in community A versus community B, you need to do statistics and analyze the data, and we do this by comparing rates. We calculate rates and rates of disease. And the fundamental question is the rate of disease in the exposed population different than the unexposed? It's a very basic question. It's not that complicated to answer. You don't need advanced statistics often. This is basic field epidemiology that we can do. But it is, you do have to have a control population. You can't just collect the rate of disease in a community and say, oh my gosh, we have 15% of the population it has asthma or has COPD or has skin irritation. The question is, what about another community that doesn't have a waste site next to it? Are those rates the same? So they must be compared. So in epidemiology, we have all sorts of studies. You don't need to focus on this. We do observational epidemiology and we do descriptive epidemiology as opposed to analytic. Descriptive is generally either a case report, someone gets sick, which then says, well, why did that person get this very unusual disease? And that's a good case there is Minamata. We also have surveillance systems, which are for descriptive studies, but are we surveilling, are we really monitoring certain conditions, or at least the environmental conditions in some of these low and middle income countries? And very often the answer is we are not. You also have cluster studies, very common in occupational health, where a whole group of workers in one part of a facility are getting a similar health effect, a similar disease, and that leads us to causation. And finally, what I've been describing earlier on is really a cross-sectional study comparing groups. So the last bullet item is what we generally do, comparing rates of disease between exposed and unexposed. But in epidemiology, analytic epidemiology, there is also the ability of studying cohorts, groups of people, and following them. So groups of people living next to a lead contaminated site or a mercury site, and monitoring their health year after year after year, answering the questions, is their health changing? So these are expensive studies. Cohort studies are complicated, but it's a great way to see if there's any change in the health of population that are being exposed. And there's also something called case control studies, where you look at, which is a more analytical sort of form of a descriptive study. So I don't have much time to go into the details here, but I didn't want to just race past these. Here's a very fascinating and sort of a comparison, sort of an example of observed versus expected. This is the Love Canal cohort, which is, of course, the group of people living around Love Canal toxic waste site in Niagara, New York. It's a very famous site, probably started this whole field. And you see that all-cause mortality on the left, that the observed Love Canal deaths is lower than the expected deaths. And then when you compare it to the state, it's also lower. It's about midway. If you look at cancers and other diseases, you'll see that the observed is primarily lower for many of these conditions than the expected. So this almost can lead you to say something silly like, gee, is it healthier to live at Love Canal? Well, the answer is no, because these studies have limitations on size and power, so that it's not quite as simple as observing rates of disease. In most of our field, I believe we'll see very obvious changes in rates of disease. But in the Love Canal cohort, which is very interesting, you would expect higher rates of disease. But let me just say that the cancer for the people living near Love Canal, while there was heavy exposure, has not been conclusively defined, meaning that we're talking 30 years, 40 years of exposure, of latency, so we still may see diseases coming about from this exposure. But this is similar to what we're doing. Think of our observed and expected. Instead of Love Canal would be a tannery in Bangladesh. And as far as symptoms, I just wanted to show the application of the odds ratio. And here you see for something like headaches, for this population of exposed versus a control population, a odds ratio of 1.6 to 7.1. 1.6 translates to 60% increased disease, as opposed to 7,000%. So that's the range there. So the unit we're generally looking for is the relative risk, or the odds ratio of this. And for this particular exposed population, you could see positive findings for just about every single acute health effect, which is sort of what we're focusing on. So in public health, what we're trying to do is monitor the population to help us determine what are some risk factors. And once we know this, we can then intervene and sort of go back and make sure that the implementation is successful. But the key here is surveillance, and this is something that is not built into low and middle income countries all the way. So we're very good at measuring contamination. We're also good at measuring exposure to people. or at least anticipated pathways. And the final is disease, quantifying environmental disease. So this is something that you and I will all do together in the future. I want to leave you with this last slide because there are a lot of questions. It's a short presentation, but hopefully I've whet your appetite. Here are some basic questions. You have this slide. I don't want to read over it, but there's a lot of questions. Let me just bring you to the first box on the top left that says, what are we looking for? And there's an interesting question there between 3 and 4. Elevated levels of toxin in the body. Does that mean someone is sick? So when someone has a blood lead of 20, are they sick? And it's both a epistemological question as well as a medical question, and one would very say, no, it doesn't mean they're sick, it means there's a toxin in their body, but we don't have clinical disease, or we don't have per se a condition. One can think of it as having high cholesterol. Does that mean you have heart disease? So it's not quite as simple. So the line between number 3 and 4 and 5 can get very blurry sometimes. The rest of this, I'll let you look at it, and I generally believe that starting at the clinic level is probably the most effective, because these are the people that have first-hand effect on seeing the disease. So I think my time may be up. We have time for questions. I'm going to stop sharing this screen so I could see the dialogue. Okay. Thank you very much, Lucy.
Okay, thank you very much, Jack. Indeed, now would be time for questions. Can we have any questions from the participants, please? You can also ask your questions in the chat if you would prefer. Well, to begin, Jack, I did have a small question.
Hello.
Yes.
What would you say? Oh, sorry, go ahead.
Hi, hello. Okay. Sorry, my English is not good. I speak Spanish, but thanks for your presentation. My question is about the methodology in the cities, because what is the different studies in the rural zone and in the city, like to Bogota, city with 10 million.
Yes, and that's a very good question. It's a very insightful, because cities are very complicated and you have many confounding variables, meaning you have many other things that may contribute to disease. So when you look at a community in the mountains, near a waste site, maybe a pottery or mercury or lead recycling, there's not much going on as far as other exposures and activities. But in a city where you have traffic and buses and gasoline and other exposures, and a very heterogeneous, a very mixed population, the assessments have to just be much more analytical, much more precise. So you bring out a good question, that what I'm describing is very nice in a very perhaps a rural area in Africa, but when it comes to a city, these exposures are much difficult to assess and be definitive about.
Okay, thank you.
Mm-hmm. Yeah.
Okay,
I think maybe I think maybe in line with that also, if I could say that the good part about cities is that generally the resources are higher and the population density, of course, is higher, so that you may have better access to surveillance systems. So generally the clinics in the cities are, forgive me, better than the clinics often in the rural areas of a country. So that's on the plus side, that's a good part of doing some of this in the cities. Okay, thank you.
Okay, thank you for that question. Any other questions?
Hello, this is Marie Concordel. Can you hear me?
Yes, hello, Marie.
Yes, I can.
Hello, Jack. Thank you very much for your presentation. It was very interesting. I was wondering, in your presentation, you are quite general, but you kind of hint that contamination is in one place, and you are looking at how this one place is contaminating people around. How does it work when you have some pollution that I would say that travels? For instance, you have a pollution somewhere and then it gets in the river, and the river brings the contaminants down. And are there some specific things you should do to study this kind of thing?
Yes, yes. When you first were asking your question, I was thinking, of course, of air pollution, which is it's also along the same lines, and it's in some ways has to be studied at a much broader level. So as opposed to a community health district, there would be a regional or even a state health district for air pollution. But your question regarding water is even more complicated, and it is very difficult. And as far as chemical pollution in a waterway affecting downstream populations, establishing causation is very difficult, and I have to say no real study comes to mind of that being done. There are cases of chemical contamination then being picked up in municipal water supply and shared with people, but those tend to be both rare, and so what I'm getting to is it's probably happening, but elucidating it is so difficult that I've not seen it. So it is a real challenge. And then when you consider the low levels of some of the contaminants, it's also makes it even more complicated. Something like mercury, which may float in the water in the suspended material versus settle in the sediment and be picked up with fish. So it's, forgive me, I think orders of magnitude more complicated and difficult. Yes.
Thank you.
Okay.
And Jack, I was also wondering, when you go to health clinics and you ask questions, how difficult is it to convince the doctors, the nurses, that the symptoms they see are due to pollution and not to just natural causes? Or how do you identify pollution versus other things?
Yes, and my experience has been that the physicians, the recipient physicians, are very eager to learn about environmental contamination and occupational diseases and go beyond their standard training. I work with a group in at Mount Sinai in the U.S. We do some training of physicians, and they're always so receptive. So I would say, almost quite the contrary. You would think they would say, oh, this is not happening. But my general experience has been when we're invited in that they're really eager to learn about this and study it. So I think there's a strong willingness. The problem is the medical training of the country, and that it's so focused on infectious diseases that some of these other diseases, chronic diseases, don't sort of make the radar, as they say. But in general, nurses in particular, they're usually very willing to learn. But I must say they are overwhelmed very often in these clinics, that there's so much work to do, so few resources. So you do have some that really resent saying, oh, gee, now I have to do this also, and I have to record this also and send this this way. But initially, I would say they're very receptive.
Okay, thank you.
Thank you, Jack. My name is Natalia, and I have a question. Your presentation was really interesting, but I have, I would like to know what can we do if we don't have enough clinical information about sickness evidence, but if we have identified a hazard or a toxic place. Are there models of sickness related to this contamination, or can we relate this to parameter?
Yes, and it's a good question. The best one, the strongest one we have, of course, is with lead. It's a rather easy material to measure in blood. It's something clinics can do very easily. But for other exposures, we don't have quite a good biomarker and a good what's called a marker disease. There are some, for example, you probably know that asbestos causes a very unique health effect as mesothelioma, cancer of the lungs, a very unique cancer. So one can say if you have this disease, you absolutely were exposed to asbestos. The problem with many of our environmental toxicants is they have multiple symptoms, and it then gets complicated with multiple children of different ages. So you have this sort of bias. But I do believe that speaking with the clinics, the physicians and the nurses at these clinics, with a systemized approach. How many people have you seen in the last month with this condition in children? How many have had this, and this? I think you'll be able to piece together a workable profile of then how to proceed in investigating it. Yeah, and then the last thing is establishing surveillance systems so that for children, certain conditions get reported upwards, so that once we have the data stored at the ministry in an electronic file, people like you and I can come and analyze the data. So that's why data recording is sort of pretty vital in this.
Okay, thank you so much for the information.
Okay.
Okay, do we have any more questions from our participants? Jack, if I may, I did have one question. How hard is it to get information from children when you try to ask them what health effects they have? I mean, is there different methods that are used to get the information? Maybe asking them to play a game or something of the sort? Have you had to use that in your work?
Yeah, not being a clinician, I generally don't do those activities. But in the area of cognitive assessments of children, this is where just think of an example where we send a combination of a child, a neurologist, psychologist, and we do testing of children's mental capabilities and limitations, and also some physiological measures of neuropathy. And you send this team into a village, you test 500, 200 children in a village, and then also simultaneously measuring their blood lead. This is the type of activity that would be wonderful to answer the question, is there damage? Are there health effects? We know there's blood lead in there, there's lead in their blood, but is there damage? So asking kids about their health, you're right, good luck. Asking parents about the children's health is better, but testing the children themselves would be the best. And testing them in a clinical way, so that it's sort of definitive. And And that would definitely be better. But you could probably figure out, Lucy, that getting highly trained people or teaching people how to do this testing and then implementing it can be complicated and quite expensive. So bringing a team from, let's say, Germany to go to Africa to test 500 children for cognitive deficits in a village is a great thing if we can find money to do. But it is a bit of a challenge, yeah.
But I imagine for some of the effects that are visible, I mean, they're very visible, so it's easy to see if, for example, a child is just has a mental impairments. You can probably see that he's maybe not active and has more difficulties in certain tasks. But mostly for the other kind of effects that are, either common to many different exposures or more difficult to find. It must be hard to find that in children.
Yeah, and I have to say, there's a lot of hearsay observations from our staff that they'll go into a village and they'll notice the kids just don't look right. They're cross-eyed, they're behaving strangely, they seem impaired. And this is sort of just observational data. It's hard to quantify, is this statistically true? But I have heard from many of our investigators that the children look sick. And then from there, sort of, answering trying to quantify that better. But absolutely, I've been in villages where I've seen children that just, don't appear to be, forgive me, normal for that age group.
Okay.
Yeah.
Okay, thank you. Do we have any more questions? Okay, then, if we have no more questions, I'm going to go ahead and wrap this up. Please all remember that if you do have any more questions, you can always send me an email or send an email to Jack. We'll be happy to share the contact information. Please also note that sorry, go ahead, Jack.
Well, I just want to thank everybody for attending. I know the time is sometimes rough for people, but please call me, email me, and I'd be happy to share with you some more information on this, or at least direct you into people who are setting up some of these programs. So thank you very much, everybody.
Please also note that a recording of this presentation and the previous presentations will be present on the GAP website, so you can go consult those whenever you want. And we hope that you will join us for the next info session on Thursday, April 6th at 8 a.m. New York time. I will be on hexavalent chromium remediation, and it will be done by Sachin Sharma. Same connection info as usual. Thank you all for your attention. Bye.